morning, Chairman, sir. I'll be discussing one of the most difficult aspects of orthopedics. This is regarding the badly damaged hips. So we could have a severe damage in hips due to infections, neglected trauma, failed osteotomies around hip, or failed orthoplasties. It's a challenge for orthopedic surgeons to deal with situations like post-infective fascial arrest, tuberculosis, then post-septic sequelae that are carried to the adulthood, then failed open reductions for neglected dislocation like this, failed osteotomies. Together, these constitute a very difficult group to manage. We don't have many options available for treatment, and things are even more difficult in children. Many people who are good at orthoplasty would say that this is the optimal treatment, but what textbook says, this has been done, looks good, but the limb remains 4 centimeters short and the abductor function is poor. So we don't want any cosmetic x-rays, rather we would like to have a functional hip. Then what would an ideal treatment mean? It would mean we should provide a stable hip that's mobile, pain-free, with no limb length discrepancy, with an improved gait. And of course, in this part of the world, people would love to squat and then would be able to kneel for prayers. Can we offer this all? I think yes, with Elizarov technique. How does this work? We create a pelvic support proximally, and then this has to go in valgus, and then Elizarov helped in doing this method that this was the previous chance osteotomy, but we would not be able to counter the valgus of the proximal fragment. Instead, he introduced another osteotomy here, which would be used for lengthening as well as varicization, so that the ultimate mechanical axis is restored to a new position. Where to support the pelvis? It could be within the acetabulum, under the pubic bone, or around the ischial tuberosity, where it would match the ischial tuberosity. This is my own representation. You could have it support here. This would be the proximal osteotomy, and then this is in valgus. This is the distraction zone, which we lengthen at, and at the same time we varicize, so that the final mechanical axis is restored here, and in this position, restored here. I'll be sharing my experience with this. Since 2001, I've been practicing this, and for the last 16 years, 17 years, we have had 30 such difficult situations, and with a mean follow-up of 8 years, with the longest follow-up of around 16 years. There were 18 females and 12 males in an age group of 14 to 39. Right hip involved more often than the left. And all patients had associated limb length discrepancy as expected. The maximum was around 10 centimeters with an average of 5.93. You have to have a good homework. For an excellent outcome, one needs to have an excellent pre-op workup. So how do we work up? We routinely include x-rays of the pelvis, then full-length radiographs or scanograms to assess the deformities, limb length discrepancy. Then this is the adduction view. This tells us where we have to osteotomize the bone. Then we do an affected limb stance view. That's we ask the patient to bear weight on the affected hip and see how much the pelvis drops, because this is going to give us a good calculation for eradication of the limb and the Trans-Lundberg gait. Where should be the first osteotomy? Where the adducted femur touches the ischial tuberosity. Then how much valgus? This we do from the Paley's method. So this is the single leg stance view. The pelvis is dropped down, and this is the amount of adduction. According to Paley, if you are able to abolish all the adduction what's available there wouldn't be any drop of the pelvis. Hence, there wouldn't be any Trundlenburg gait. Then where has to be the second osteotomy? We have done the first osteotomy here. Then the second osteotomy is plotted from a line that grows from the tibial axis and then intersects the new mechanical axis. That's somewhere here. Could appreciate it here. This is the first osteotomy and the second osteotomy. As per previous calculations and intra-op calculations, we osteotomize here. Surgical technique, done under spinal anesthesia on a fracture table. The pre-planned construct is mounted on the femur, and then we perform minimally invasive, low-energy osteotomies. This is the only amount of invasion you have. One osteotomy just here, another osteotomy here. I've been using this 5/8 in most of the patients now. Here a dummy ring, one arch and another arch. It's a lightweight construct. Then once we are done with this, we wait for 7 days as usual, perform the lengthening at the distal osteotomy in a differential manner so that the limb is lengthened and varicized. The mechanical axis thus is restored. Then the region rate needs to be monitored regularly. This is how we do it. This is the proximal osteotomy, and then lengthening is happening here, and it has been varicized to achieve this. This is during consolidation. What about those patients who have a fixed hip? Yes, what we do, we make them mobile but unstable in the first stage by girdstone excision, and then at the second stage, we add pelvic support osteotomy and then lengthening osteotomy. We had 4 such patients in this series, like this tuberculous fibrous ankylosis. I'm going to share some case examples. This is a 16-year-old girl, reported with 1-year-old neglected fractured neck of femur. The trochanter has migrated to much high remnants of the head, and she has associated 4 centimeters of shortening. Post-op X-rays during consolidation, one osteotomy, the lengthening is consolidating. Then this is consolidated, the frame in place. And look at this. This is the new image now. The abductors are lengthened, adding to the functionality of the hip. And this is the new mechanical axis. And you have achieved lengthening, you have achieved support. The trochanters are level, limb length is equalized. Most important, look at the function. Able to squat, and look at the improved hip biomechanics. This is the affected limb, the other limb. The pre-op grade has both shortening as well as a lurch, and at 3 years post-op is walking brisk. This is tuberculous fibrous ankylosis, girdstone. It's now unstable but mobile. First osteotomy, the lengthening osteotomy here, and this is the new reconstruction. Pelvic support here, lengthening here, limb equalized. Function. This was a 14-year-old boy who had been attempted many times for open reduction of dislocation, but got infected. Now we are in a fix. What to do at this stage? He's only 14 and is infected and is associated with a fixed flexion deformity and 4 centimeters of shortening. Again, we performed girdstone excision first, then the reconstructive procedure. Equalized length, this is the pelvic support, and this is the lengthening area. Both healed nicely. equalization with corrected deformities. And this was a 17-year-old girl, post-septic sequelae, such a bad hip, with all altered anatomy and 5 centimeters of shortening. Again, same thing was done, function, and look at her gait at 10 years post-op. She has a brisk gait and Trundlenberg. "35-year-old lady with tuberculosis left hip. This is after post-gallstone excision. Post-op X-ray, and this is 9 years post-surgery, doing her routine jobs. Ability to squat and gait. She has 1 centimeter of shortening, which I ignore in view of having an excellent knee range of motion. This is what I routinely do, that monitor the regenerate and monitor the knee range of motion. If it means leaving 5 centimeters short, it would be better than jeopardizing the knee range of motion. 32-year-old engineer with post-septic sequelae and 7 centimeters of shortening. I don't know how to replace this joint and how functional it would be after replacement. Usual workup, immediate post-op, distraction and consolidation of the regenerate. Even at the age of 35 years, he has an excellent regenerate. Depends on how meticulous you are with the low energy osteotomy. Limb length equalization, function, gait comparison, post-septic sequelae with 5 centimeters of shortening, full-length scanogram, adduction view, and this is the drop view where you calculate the angles and look at where the trochanter is going, how much unstable it is. This is during consolidation and lengthening. This is the regenerate, function, mechanical axis. Preoperative gait, and gait at 3 years. Effective biomechanics of hip. All except 3 patients we achieved exact length at an healing index of 1.55 months per centimeter, and the pre-operative hip hair score improved from 58 to 82, and then gait improved from moderate limp to no limp in 22 patients, while 8 patients persisted with mild limp. Our goal is to get limp from moderate to nil or moderate to mild. We had some complications. These are very common, but they are not bothersome, can be managed easily. We had 1 fracture at the regenerate, and we had 1 case of an anterior bowing in a patient with massive lengthening. This is the regenerate that was bowed in the anterior-sagittal plane. We conclude, this technique provides an excellent salvage in these badly damaged hips by restoring stability, improving hip biomechanics, and addressing limb length discrepancy. Thank you very much for your attention. And I would like to thank the organizing committee for giving me this opportunity to present my work. Thanks once again from this beautiful alley. Thank you very much.